Good evening, everyone. My name is Susanna Looney. I will be the moderator for today, along with Dr. Al Rundio. I obviously can't see anyone because my screen is frozen, but I know that the people are here. So I'm happy that people are attending our conference tonight. Before we begin, I just want to go over some housekeeping details. Please mute your microphone. If you don't know where your mute is, it's on the bottom of the screen on the left-hand side. Also on that bottom where the mute is, you'll see mute video. You'll also see down there if you have any questions and answers, which we'll get to that in a second. Post your questions and answers in the chat box. Dr. Rundio will be moderating that and be answering the questions for Bill, bringing up Bill's attention. Please be sure to fill out your daily surveys. You must complete the daily surveys. These can be found on the ASAN website. If you go to continuing education, you scroll down to today's date, July 7th, week 2, and you'll see the link, also the video when it's available to today's session. This conference is offering, this summer series is offering 8 nursing CEUs. This has been approved by the California Board of Nursing, and I'd like to thank Dr. E.M. Garcia for his assistance in getting our webinar approved for this certification. If anybody should miss a session, all sessions will be recorded for viewing. If you're unable to attend any live sessions, this is our second one this week. You can go onto the website under continuing education and you can see all the sessions once they occur. Real quick, I don't know if anyone was here last week, but this is our board, our ASAN, American Society of Addiction Nursing Board of Directors. Bill Carrick is our president. I am the president-elect. Dr. Lorman is our treasurer. Ginny Coletti is our secretary. And our board of directors include Dr. Carolyn Baird, Fran Campbell, and Dr. Mary Fouget. I hope I didn't bash your name. Okay, this is our schedule for the summer series. Last week we had Dr. Al Rundio present. Today we have Dr. Bill Lorman, the Neurobiology of Addiction Concepts and Pharmacological Concepts. Next week will be Bill Carrick. Week 4, Connie Mealy, Adam Barrett, Dr. James Ferguson, laboratory test. Week 7, common psychiatric disorders. Week 8, holistic addiction services. Everything will be archived. All the videos will be on our website. Before I introduce Bill Lorman, I would like to thank Dr. Al Rundio, E.M. Garcia, and Connie Mealy for their work in getting this, coordinating all of our summer series and all the speakers that we'll be having for the 8 weeks. So our guest presenter is Dr. Bill Lorman. He is a nurse executive practitioner and has over 45 years in the field of nursing. He has made an enduring impact on patients suffering from addiction and has held multiple leadership positions in the nursing profession. He has provided a vision and support to the nurses in the state of Pennsylvania through his work with the Pennsylvania Peer Assistance Program for Nurses, PNAP, as president and chair of the board of directors. And he currently serves as a member of the board. Through his organizational leadership, he has established international and state guidelines and policies related to the care of individuals with addictions, including nurses themselves with addictions. He has provided addiction treatment education to undergraduate and graduate nursing students at Drexel University, as well as a part-time faculty member, and also when requested at other universities as a visiting lecturer. He has conducted numerous webinars and presentations on addiction treatment, pharmacology, neurobiology, and other topics related to addiction, thus educating thousands of nurses, believing that all nurses are addiction nurses and critical to the care of addictions. He also works with hospitals to present sessions pertaining to identification, screening, brief intervention, and referrals to appropriate treatment, along with de-escalating techniques when facing the aggressive and challenging patient. Currently, Dr. Lorman maintains a private practice providing treatment to patients with general psychiatric disorders, substance use disorders, and provides psychopharmacological and psychotherapy interventions, including medicated assisted treatment. And lastly, in his free time, Dr. Lorman is self-employed and provides services as a legal consultant in malpractice issues. Thank you, Bill.
Okay. Let me share my screen. There we go. Just a housekeeping thing. At the bottom, you'll notice that there are two icons. One says Q&A and another one says chat. Please, if you have any questions, put them in the chat, not the Q&A box. Okay. So let me get rid of that. Our presentation is on the neurobiology of addiction and some pharmacological concepts, and I'll be talking mainly about alcohol and opiates because they are the most common of the abused substances, and so I go through management of those two disorders. So I'm going to start with biologically what's going on in the brain, and we have the mesolimbic pathway, which starts down at the bottom at an area called the ventral tegmental area, the VTA, and at the and there are neuron tracks that run along this area and end in the nucleus accumbens. This area from the VTA to the nucleus accumbens is called the final common pathway for reward and pleasure, or pleasure seeking. And so what's interesting about this is every time we do anything that provides satisfaction, contentment, happiness, that area lights up. All right. The belief used to be initially that the area had to light up before, or that we experienced the emotion, the positive emotion of happiness, and then the area would light up. We now know it's exactly the opposite. We cannot experience happiness, contentment, satisfaction unless that area is stimulated and lights up. So the bad news is that the same area is affected by the drugs of abuse. So anytime anybody uses a controlled substance, that area lights up. But the bad news is it lights up between 10 and 100 times greater than our most satisfying natural feeling. And so you can certainly understand why drugs of abuse create such a high level of euphoria that people just want to replicate it over and over again. All right, so here are, I've just listed some models of 4 addicting molecules: nicotine, alcohol, heroin, and cocaine. And the one thing that you should immediately notice is they look entirely different. Different sizes, they have different molecular weights. And so the belief was initially that since they look so different, since they are so different, ones are so much larger than other ones, that they must therefore go to a different area of the brain, that different area of the brains would receive different drugs of abuse and cause the effects that they did. However, we now know that there is a single pathway to addiction. And even though they have very different structures, they exhibit, oops, sorry. First, there is, at least initially during the process, acute reward, which is euphoria, right? And then there's chronic reward. So the euphoria is not as great, but the chronic reward ends up being over time numbing, a buzzing and a numbing, so that the person doesn't feel any of the negative emotions that they heretofore have been getting as a result the brain and the brain structures that occur with use. There are negative withdrawal symptoms for just about all the drugs of abuse. There are a couple drugs of abuse in which there are no identifiable withdrawal symptoms, but for the vast majority of them, there are withdrawal symptoms. There is associative cue learning. That is the contemporary term for people, places, and things, as AA talks about. Which means that externally there is learning going on in which craving occurs, and then there is relapse, and the current contemporary term for relapse is incentive motivation. So the incentive to relapse, or the motivation to relapse, is the person's going through withdrawal, and in order to stop the withdrawal, they end up seeking the drugs that they've been using. So this is a graphic of a single neuron in the mesolimbic pathway. So down on the left is the ventral tegmental area, and the neuron traverses through the brain to and ends in the nucleus accumbens, which is up there on the right. And all the drugs of abuse, they all end up going to this drug of abuse, uses a different neurotransmitter system to do its dirty work. So for any drug of abuse to have its effect, it has to work on a receptor found in the ventral tegmental area. So alcohol uses the GABA system. Cannabis or marijuana uses the cannabinoids. The opioids all use the mu opiate receptor. Nicotine uses the acetylcholine receptor. The hallucinogens use the 5-HT or serotonin receptors, and PCP and also alcohol antagonize the glutamate receptors. And I'll say something about the nicotine receptor in a minute, but an interesting factoid is that the psychostimulants like cocaine, the amphetamines, and all of the prescribed psychostimulants bypass the ventral tegmental area and go directly to the nucleus accumbens, where they can do two things, actually. They can stimulate the dopamine receptors themselves, or they can reverse the act, which is that blue bubble that's in the can. It reverses that that pump so that it actually chemically pulls out additional dopamine to really fill the synapse and really super stimulate the dopamine receptors. Now, going back to the nicotine receptor, there's something interesting that occurs in the acetylcholine receptors that nicotine hits in the ventral tegmental area, that none of the other receptors have that particular model that it uses. And the acetylcholine receptors, when nicotine hits those receptors, the acetylcholine receptors desensitize. And the tobacco manufacturers have known way before the biochemists, the scientists that work in addiction, knew that that particular receptor desensitizes, and they knew that it desensitizes after 1 or 2 standard cigarettes. And it takes about 3 or 4 hours for that receptor to resensitize. And this occurs in about 95 to 98% of the population, that the acetylcholine receptors in that area desensitize. In the other few percentage in the general population which doesn't desensitize, we call those folks the chain smokers, because it doesn't desensitize, so they get the euphoric effects of the tobacco every time they smoke. But in the rest of the population, it only takes 1 or 2 cigarettes. usually one, but in some people two, for that particular receptor to desensitize. And we can tell that in the general population because they have a cigarette or two and they're fine. And if you work with smokers, you know that after 3 or 4 hours, they're up and it's time for a cigarette break. And that's the point that you can pretty much figure out very quickly that those receptors are resensitizing and the cravings begin, and the person has to go out and have a cigarette or two, and then they're fine and they come back in and they're okay for another couple hours until those receptors resensitize. So that's an interesting factoid to know about the nicotinic acetylcholine receptors in the ventral tegmental area. The body, the brain makes its own morphine, right? We know it is beta endorphin, and it makes its own marijuana, a relatively newly discovered neurotransmitter called anandamide, which hits the cannabinoid receptors. It even makes its own antidepressants, its own anxiolytics, and its own hallucinogens, actually. So we know that the hallucinogens, especially, people will always say to me, well, how is it that the brain can make hallucinogens? Well, basically, when we say close your eyes and imagine your living room, what's going on is those endogenous hallucinogens are creating in your mind's eye what your living room looks like. And most people can visualize in color. Some people can't, but most people can visualize in color. As we age, for the majority of our general population, those particular neurotransmitters and receptors begin to disintegrate. They're the greatest in children, to the point where children can even have imaginary, friends. They can actually hallucinate the presence of their friends. And that's considered normal, by the way. That's not pathologic. But as time goes on, we lose, for the most part, our ability to actively use or utilize the hallucinogens that our brain produces. But to some extent, we always can do that. The drugs often mimic the brain's natural neurotransmitters. As a matter of fact, if there isn't a receptor for the particular drug of abuse, then there is no euphoric effect. We know that, for instance, I always give the example of cats. Cats, 85% of the cat population have in their ventral tegmental area a receptor for catnip. And so whenever they inhale catnip, they go into a euphoric state. But 15% of cats don't have that particular receptor in their brain, and catnip has absolutely no effect on them, just like catnip has absolutely no effect on us, because we don't have a receptor in the brain that accepts that and creates the level of euphoria that the drugs of abuse do. And often drugs are discovered prior to the natural neurotransmitter in our brain. So for instance, we knew about morphine before we even knew about the presence of beta endorphin, right? Based on the effects that it has. We knew what marijuana does before we understood the cannabinoid receptors and the presence of anandamide. And we knew about Valium and Xanax before the discovery of the benzo subreceptors. And we even knew about the discovery of the site and how those particular drugs work. Is how all these drugs, the behavioral effects that they have on folks. So the transition to addiction, taking drugs begins as a voluntary choice to seek a pleasant stimulus, but for addicts, that choice is no longer volitional, even in the face of terrible personal consequences. And a lot of people don't really understand that sentence. And the big problem is the word craving. It's unfortunate that in our addictionologist terminology uses a terminology that's in the general population. One of those terms is craving. And whenever I say the word craving to you, you immediately think of a craving that you may have experienced in the past, like a craving for chocolate or ice cream or candy or something like that. And that's referred to as a psychological craving. You psychologically crave whatever it is that you crave. The difference in the addictive process is the craving, in addition to be psychological, is also physical. So it's physiologic. And physiologic craving is painful. We don't say that so much about psychological craving, but physical craving is kind of like having an abscessed tooth or a migraine. Right. So the craving is in a lot of people will explain it as being a painful presence in which the person knows that the only thing that will stop it is the drug of abuse that they've been using. And the mind goes, I mean, imagine for any of you that have experienced a dental abscess or a migraine, life stops. Right, I can tell you when I've had migraines in my youth, I had to stop what I was doing. I had to be in a quiet, dark room. I would lay on the floor, put a cold cloth on my head, close my eyes, and then just wait it through. And I could do nothing else. It's the same thing with the craving that occurs in addiction. They lose all capacity to really do anything else productive except find the drug, use the drug, and then recover from the drug. So in the initial stages of addiction, the pleasure is derived from various drugs' activation of the brain's renal area and then stimulating the nucleus accumbens, where euphoria then occurs with the hypersecretion of dopamine. And as this process continues and is repeated, the brain goes into the mechanism of dependence. And dependence leads to daily drug use to avert the unpleasant symptoms of drug withdrawal. So with time, you can just imagine that with all the dopamine being released, eventually the dopamine stores are emptied. And so there's no more euphoria. So instead, what the person begins to experience is withdrawal. And so the only thing that will prevent withdrawal is taking in more drugs. So even though they don't have the level of euphoria that they've had in the past, they've averted withdrawal. And as drugs continue to be used, more and more long-lasting changes in the brain occur, which initially, or I should say for a significant period of time, are reversible. It really takes a long time, a lot of drugs to make the structures irreversible, or if the drug use starts at an earlier age, it's much easier to make those changes irreversible. So I want to just talk about for a few minutes the biologic models of addiction, since we are talking about neurobiology here. There are two contemporary models out there now. The change set point model, of which there are a couple different variants that have a slightly different explanation, but they all talk about the change set point models, and there are three variants that are out there, talk about the dopamine neurons in the VTA and norepinephrine neurons in the locus coeruleus. And these alterations begin during the early phases of withdrawal and abstinence, and then we know that they alter the biologic and physiologic settings or baselines. That's what they do. So the first variant is really about a thermostat, right? So the variant number one of the change set point model is a model about the natural thermostat in the brain. And the way that it's explained is that neurons of the mesolimbic reward pathways are naturally set to release enough dopamine into the nucleus accumbens to produce a normal level of pleasure. So the brain's thermostat, or homeostat, we might, is probably a better scientific term, is already set in normal conditions to express the amount of dopamine related to the amount of emotional happiness that we experience, right? Now, abused drugs cause a change in that thermostat so that when the drugs stop, so you can imagine, so what's happening is all these drugs are taken in exogenously into the body and causing the release of dopamine into the to stimulate the nucleus accumbens, and the brain hectically is trying to reestablish, or I should say, reestablish homeostasis by beginning to desensitize, either desensitize the receptors or decrease the release of dopamine. And therefore it resets that thermostat so that when normally pleasurable activities, in the absence of the drug of abuse, you don't have as much release of dopamine because the brain is expecting the drugs of abuse to be used and to express a large amount of dopamine. So it very carefully decreases and rations out the amount of dopamine that is allowing to be secreted. And then also, we see an increase in the release of norepi out of the locus coeruleus, which then ends up causing the withdrawal aspects of addiction that we see when the person stops using their drugs of abuse. The second variant is a little bit different. The neurons become dysfunctional through an alteration of their resting levels of activity and dopamine release. And once again, the two main neurotransmitters are dopamine and norepi. And here, these are what are referred to as the brakes. So when the autoreceptors are stimulated, it causes a shutdown in the release of dopamine. And so we have, again, a decrease in dopamine in the absence of drugs and an increase in norepi as a result. And then there is a third variant, which really talks more about the exogenous things that are happening rather than the endogenous. And this has to do with sensitivity to environmental cues that leads to wanting and craving. And so this is where the AA model of people, places, and things comes in, which increases the cravings, and there is a reticular model which increases cravings and withdrawal symptoms. So that's that. And then the second more common model, which is the one that I prefer to use, is called the cognitive deficits model. And this is an interesting model. And it talks about the brain structures, specifically the prefrontal cortex, the nucleus accumbens, which we already talked about, and the neuronal tracts that go between the prefrontal cortex and the nucleus accumbens. And so we know that the prefrontal cortex is important in regulating judgment, planning, and executive functions. And it's the prefrontal cortex that sends signals to the nucleus, or to the VTA, the ventral tegmental area, to withhold stimulating that particular neuron, so there's no release of dopamine. And it does that utilizing the neurotransmitter GABA. So the prefrontal cortex will cause GABA to be sent to the ventral tegmental area, which then stops depolarization and then stops the release of dopamine. And so what we know that using drugs, it damages the carry the GABA, and so the GABA never is able to make its way from the prefrontal cortex to the VTA, and so the drugs of abuse take over and we'll have the release of dopamine. In alcohol, alcohol turns off GABA because the brain sees alcohol as GABA and it thinks it's producing too much, so it shuts off the GABA. So the prefrontal cortex, in its attempts to notify the ventral tegmental area through the use of GABA, the GABA is not being released. And then the opiates actually damage the prefrontal cortex itself, so that over time, the impulsivity that occurs as a result of the drugs of abuse hitting the VTA and releasing dopamine into the nucleus accumbens causes that high level of impulsivity, because the prefrontal cortex no longer is able to regulate judgment, planning, and other executive functions. So that is the fourth cognitive deficits model of explaining how addiction progresses and how it occurs. And we now know that addiction is also a neurodevelopmental disorder, in that the youngsters who begin using drugs when their brain is in the active stages of changing and growing and refining, the drugs of abuse change that. Often making it unchangeable, so that the person, so it's not reversible, so it becomes irreversible, the changes that are occurring. And so all areas of the brain are affected by the drugs of abuse, not just the impulsivity, but also other areas. And of course, the role of stress plays a very important role, as we now know, in the process of relapse. So stressors can trigger drug craving in addicts. We've always known that stressors can do that, but we never really understood how that works. So one explanation is that abused drugs raise levels of cortisol, which plays a primary role in stress responses. And what cortisol does is it raises the level of activity in the mesolimbic reward system, and stress contributes to the abuser's desire to take drugs in the first place, as well as the subsequent compulsion to keep taking them. And another area that was ill-defined in the past, we're better understanding now, which is the whole process of tolerance. And we have a better understanding of how tolerance works. And here are the steps that are believed to explain tolerance, and then the reversal of tolerance. So when dopamine is increasingly released into the synapse of the nucleus accumbens, the dopamine receptors are stimulated. And the receptors are completely full of these dopamine neurotransmitters, and as a result, in addition to causing the euphoria, internally they release what's referred to as a second messenger, and it is cyclic AMP, right? Adenosine monophosphate. And this travels down the neuron and it enters the nucleus, where it activates another protein called CREB. And CREB stands for Camp Response Element Binding Protein. Not that you don't need to know any of this, but what CREB does is then it activates another chemical called dynorphin. So what I want to point out is every reaction that occurs in the body is a cascade reaction. It has to occur over several steps, and they're all protective, so that they don't get out of hand. And if there begins to be an increase in one of the steps, we have this cascade effect from overstimulation of the receptor to the activation of CAMP, to the activation of CREB, and then to the activation of dynorphin. And then dynorphin travels back to the receptor at the nucleus accumbens area of those receptors, and it is dynorphin that desensitizes those dopamine receptors, so that dopamine no longer is able to stimulate them as they have in the past, until the drugs of abuse stop over time. And once that happens, another protein is activated, and that protein has a strange name. It's called delta phos B. And what that does is it resensitizes to the point of hypersensitizing the dopamine receptor. Because after a period of time when the person hasn't been using drugs of abuse, the brain realizes that, hey, wait a minute, we're producing dopamine now. Dopamine's being released, but it's not hitting the receptors. So it causes the release of this new protein called delta phos B, which then resensitizes or turns back on the receptors. And that causes what is in the general parlance called reverse tolerance. And this is when people, when they go out and use after a period of abstinence, will OD, because those particular receptors are oversensitized. Especially in the respiratory, when dopamine in great amounts hit those receptors, the person just stops breathing and they die. And that's that process right there. So the general principles of management, I'm going to go through very, very quickly. What we do in the beginning is evaluate the patient for the need for medication and medical management by evaluating the severity of predicted withdrawal, the presence of medical comorbidity, and the presence of psychiatric comorbidity, which all complicate the process of withdrawal. And so, you know, we want to be able to identify those parameters in the patient to figure out how best to treat them. And so there are two strategies that we use pharmacologically. One is called to suppress withdrawal through the use of cross-tolerant medications. So this is called the substitution strategy. We use a longer-acting medication to provide a milder controlled withdrawal as we begin to taper that particular medication. And then we also use another strategy called symptomatic management, which is to manage the signs and symptoms of withdrawal through the use of other pharmacologic agents like clonidine, propranolol, ibuprofen, and any of those. So in alcohol withdrawal, basically, you should all know exactly how alcohol works on the brain, which is what this particular slide talks about. And we know that the neurotransmitter systems that are generally affected are GABA and norepi. And then also, we now know that there actually are more areas affected. The calcium channels are affected, glutamate receptors are affected, and the CAMP systems are also affected in that. And the cornerstone of pharmacologic management of withdrawal is the use of benzos. So specifically longer-acting benzos, so that this is the substitution management that is utilized in the treatment of withdrawal for alcohol. We replace the alcohol with the benzos and then begin to taper them slowly. And so this basically talks about that. And so the longer acting agents are the ones that we prefer. Librium, Valium, Klonopin are used. Of course, we would never use Xanax because it's such a a short acting. And some places still use long acting barbiturates like phenobarb, and that's fine that they use those. There are some problems with phenobarb, and for the short period of time and the significantly lower doses that we use, there's really no problem. So that is still in the practice guidelines to use those. Other agents that are used outside of for symptomatic management are, as I mentioned before, clonidine, and the other beta blockers are also used, and even anticonvulsants. There is more and more literature out there that carbamazepine or tegretol works even better than the benzos, and there are some places that use that. Some detox places will use tegretol instead of the benzos or barbiturates, because we don't have respiratory depression. We don't have the possible creation of an additional addiction to a benzo. Neuroleptic agents should not be used, and unfortunately they're used a lot in emergency rooms, but these particular agents have a tendency to decrease the seizure threshold, and usually by the time ERs send them off to a standalone detox unit, the person is well on the way to having a seizure because of those drugs. We don't like to use magnesium or dilantin because dilantin has never been shown to control withdrawal seizures anyway. And then there's a whole story with magnesium, which I really don't have time to get into right now. The same thing with thiamine. So the alcohol, kind of pushes the thiamine out of the body. So these folks are thiamine deficient. So chronic alcoholics should be given thiamine to use. Opiate withdrawal. Here is a list of the opioids, and I've broken it down into the natural, the semi-synthetic, and the synthetic opioids. You can impress your friends by telling them how you know which opiate is a naturally occurring, which is a semi-synthetic, and which is a synthetic. And we now know there are two phases in the withdrawal process. We have acute withdrawal, but we also have protracted withdrawal. And you should know the difference between the two and what they are. An acute withdrawal has a lot of different symptoms, but we know, and I tell people, it's as if they have a bad case of the flu, is what it looks like. And it's unfortunate that these people will show up at their primary care physician's office and they'll be misdiagnosed as having a bad cold or the flu. And a lot of times, because of the anxiety that the withdrawal creates, they may walk out of the office with a prescription for Xanax. Now, in protracted abstinence, what's happening is the brain is restabilizing itself. So all the drugs of abuse in protracted with abstinence have left the body. They're out of the body, and now the brain is in the process of restabilizing and creating homeostasis. But to do that, it creates, because there's an excess of norepi, of glutamate, and a decrease of GABA and dopamine. And so we will see during this period changes in vital signs, decreased sensitivity of the respiratory center, and irritability, insomnia, and even the presence of cravings. And so even if a urine drug screen is taken, it generally will come up negative because all the drugs have left the body during that period of time. And so here's the clinical picture of opiate withdrawal and what's going on with that. Let's see if there's anything here that I really want to talk about. Well, in withdrawal, we know that there's noradrenergic hyperactivity going on, and so we will give medications to neutralize that and neutralize the any of the excess neurotransmitters that are in the brain, and then also augment the neurotransmitters that have decreased or attempt to do that. So in summary, there has been substantial progress in the development of pharmacotherapies for the treatment of substance use disorders based on our knowledge of neuroscience and neurobiology. And these treatments are utilized in conjunction with a program addressing psychosocial needs of the patient. So psychotherapy is just as important, if not more important, than the ongoing pharmacotherapy. And research continues to broaden the number of pharmacotherapies available, and the search for effective medication treatments for other substance use disorders, such as for stimulants and cannabis use disorders, continues. So that is the end of the presentation, and we have a couple of minutes to talk about any questions you might have.
And just a reminder, if anyone does have questions, if you'll put it into the chat box.
Was I losing connectivity throughout?
Yeah, there were some issues where you got real slow.
Oh, I'm sorry. Sorry about that.
I told people you were having internet, your internet was unstable. I think it's weather related. I know it happens. We all live across the country, and weather, you know, can affect our service.
Yeah, we've been having storms in the South Jersey and the Pennsylvania area the past few days, off and on.
Right.
So, but if anyone does have questions, let me go to the chat. I think I may see some more questions. Okay, there are some questions, Bill, I will read to you. Let me go to where the questions actually start. Do you see Neurontin used concurrently with other medications for detoxification?
Unfortunately, yes. And there hasn't been any really good studies demonstrating that Neurontin has any true effect. The belief is that it's placebo effect in the detoxification process, but a lot of folks want to use it because we now know that it has a snowing effect on a lot of folks, and they want to continue it after they leave detox. And so that Neurontin is becoming problematic in this population, which I'm finding more and more. And I see people in the outpatient that want to stay on their Neurontin because they say that it makes them feel better. And I don't like it when they say that. When a person that's coming out of a active addiction says, Neurontin makes me feel better. And so I will work with their primary therapist to try to get them to taper off of it.
Okay. The next question is, how does methadone react in patients that are going through protracted withdrawal?
How does it react? I'm not sure. Methadone is one of those medications used in medication-assisted treatment to keep the person from having cravings. So that's basically what we use it for. So it's as if there's still, I mean, methadone is a full agonist opiate, so it's not supposed to produce the same level of euphoria as the other full opiate agonists do, and that's why it's used as if the person is continuing to use, so they don't have the cravings and they don't have the increases in glutamate and norepi that we would see.
Okay. Next question is, I've learned that pause, post-acute withdrawal symptoms, last up to 18 months. Is there new evidence that it only lasts about 6 months?
Well, the addictionologists prefer to use 6 months, even though they know that that's probably too long. Most addictionologists will say no longer than 3 months, actually, from their experience. The unfortunate thing is that the DSM says 1 month. So the DSM says if the person has any symptoms after a month of abstinence, then we have to give them a independent psychiatric diagnosis. So the DSM fathers, in all their wisdom, which is very much against what the addictionologists wanted when the DSM-5 was put together, unfortunately, the addictionologists lost, and the time frame is 1 month. So we must give them, according to the DSM, a diagnosis after 1 month.
Okay, and then next question, excellent and helpful. Can you talk about the emerging use of psychedelics for AUD?
You mean, I really have not read enough about them. I have plenty of articles that for some reason I'm blocking to read about how they're using. I mean, I'm just so turned off by giving those folks psychedelic medications, for that I'm sad to say I need to get over that block and read more about it. But I mean, I could make something up, but I'm not going to do that. I'll just say that I don't know.
Yeah. This is another common isoneuratin used all the time. They call it the wonder drug up in Boston. It's now used almost routinely by so many physicians, and they are teaching the MPs to prescribe it.
Yeah, and we see it all over. It's all over the United States, actually. And that's why a lot of the addictionologists are now beginning to question, what is it about Neurontin that makes it the, quote, wonder drug, that so many folks in an addiction or newly out of an addiction like it so much and want to stay on it. That in and of itself intuitively says, there might be a problem here. And so I'm very careful with that. It's the same thing with Seroquel. Between Neurontin and Seroquel, I see patients, a vast majority of patients that I see coming out of detox and rehab in my private practice come in on Neurontin and Seroquel and don't want to come off of them. And that's
I don't know about people's states, but I know in New Jersey, we are tracking the PMP if we prescribe Neurontin, even though it's not controlled yet, it is being tracked.
Yeah, and a lot of they've been talking about adding Neurontin to make it a Schedule 5, yep. Actually. Which actually is what happened with pregabalin, with Lyrica. When Lyrica came out, it was supposed to be used for anxiety, and it was going to be a straight prescribed medication. And we in addictions loved the idea that there was a new anti-anxiety medication. And at the 11th hour, they found that it actually goes to the ventral tegmental area and hits GABA-like receptors in the VTA. And so at the 11th hour, they made it a controlled substance. Now so far there haven't been studies that have actually demonstrated that Neurontin hits that area, but there's a lot of folks that believe that it does, and we just haven't been able to figure out that yet. But I'm sure when they do find that out, it'll become a controlled substance for sure.
Yep, I agree with you. If anyone has any other questions, I think we're through the questions. Just post them now. Wait a minute or so. So the recording should be available by this Thursday on the ASAN, the ASAN website. Don't forget, we are doing the webinar series every Tuesday at 7 p.m. Eastern Time through August. Next week's presentation will be Bill Carrick presenting on alcohol substance use disorder. Thank you for all being here, and I look forward to seeing everyone next week. Take care. Thank you, Dr. Lorman, for an excellent presentation.
You're welcome. Take care, everybody.